All right, it's 5:30. This is the Marine Advisory Committee, October 10th meeting, and our diving safety symposium, which appears to be well attended. Do you have the attendance sheet? You do not? All right. Does anyone know where the attendance sheet is located? All right, we're going to go off of this one. I'm just going to call off of here. We've got it. What's that? Yeah. Hey, pass it over here. Yeah, you can sign it in a minute. All right, Mark Moore, Melissa Pino, Glenn Conrad, Clint Rutherford, Joe Denman, Derek Green, Peter Gaddy, I'm here, Kathy Watson, Kerry Freeland, Michael Lewis, Eileen Beard, Robert Turpin, and Mark Nicholas present. All right, we have our diving safety symposium. I will turn it over to Captain Turpin. Or no, we're going to approve our minutes first. Approval of the minutes from the last meeting. Does anyone see any edits, additions, comments? Do we have a second? All in favor?
Aye.
I'll abstain. I was absent at the last meeting. All right, now without further ado, Captain Turpin.
Thank you, Mr. Chairman, and welcome everyone. We appreciate all the participation tonight. We hope to make this both educational, informative, and perhaps even entertaining. We're going to run through a scenario tonight, and we hope to make it relevant for all of you, although there is no one flow chart, one checklist, one float plan, or anything that can fit all the scenarios. We're going to give you tonight the Escambia County Marine Resources version of these float plans and checklists, and we'll also have these online. But we're going to run through a scenario, and that will show you what our version of diving safety looks like, and will be a step-by-step sequence that will allow us to see the chain of care that leads one to, if necessary, over to one of our recompression chambers. So I do have some folks that I want to introduce online. We've got Jim Chimiak with Divers Alert Network, we affectionately refer to as Dan, and he's going to be participating via Teams. On the Escambia County Marine Resources team, I'm Robert Turpin, of course, and this is Mark Nicholas. We're both licensed captains. I'm a former instructor, but a dive master with a federal agency dive master rating for scientific diving. Our dive master that we utilize most often is Paulo Guillo. He's also a U.S. Coast Guard licensed master, a dive master, and a scientific dive master. And we've got Jared Aliff with us tonight. He's what we call our surface safety support, and safety is his middle name. So you'll see tonight how his role in our diving operations is conducted. We will have our various plans. We have what we call a SEW plan. That's like sew with a needle and thread. S stands for safety. If we focus on safety, we hopefully will prevent the letter E, which is emergency. And then once we've accomplished all of our safety items, then we can safely conduct our work, and that's the W in the SEW plan. So we'll have these on Escambia County's webpage. We also file a float plan that allows for our county to maintain direct control over our safety. As if we need it, they know where we are, they know who's on board, there's a description of the vessel, and that will also be online. And then also for all of our dives, we now dive according to a written dive plan. And I usually write the dive plan in consultation with Mark and Paulo, and we submit those to our risk manager and to my direct report, Tim Day, in the back. Tim is also a member of the dive team, but because he's a deputy department director, he finds himself diving a big pile of paperwork and doesn't get to dive with us as much as we would like, and certainly as much as he would like. But Tim is one of the original dive team members. He and I started this fund back 23 years ago. So we try to focus on our attitude towards safety. And it may seem a little bit much, but I've been diving since 1975, and I ran a liveaboard dive boat. I also ran the academic research diving at University of West Florida, and I've been running the Escambia County's diving program for 23 years now. I say that not to brag. I say that because I am humbled by what I got away with by not focusing on safety. And I know that I've used up every bit of luck for myself and probably any two of the other divers in this room. So now I'm extra cautious and extra focused on safety. So I hope that tonight we can show you our operation, and then after we have our scenario, we're going to have a discussion, and then we also have a couple of presentations. So without further ado, I'm going to grab the other microphone. So we're not going to bore you with what it takes us to get on site, but as you see here, we're simulated as being anchored on an artificial reef. We've got the Escambia County vessel here. This was our first vessel, and fortunately we've grown our fleet a little bit, but we do have all our gear. And one of the things that we really focus on is always keeping ourselves hydrated well in advance of even getting on the boat. So you'll hear us talking tonight about, hey, have you had enough to drink? Are you hydrated? So we're all going to be using that. So right now we're simulated to be anchored on one of our artificial reefs, and we have our dive flag is up. We do have a surface safety supplied air that we lower down on an anchor. Paulo, you want to deploy our Oh, okay. So it is over the edge. So these hang down at 20 feet and allows us, if we're running low on air, we can maintain our safety stop and breathe off of that, and then we'll have hopefully enough air in our tanks to make it to the surface. So right now we're going to simulate suiting up. Mark and I are going to do a dive, and I'm going to turn the microphone over to our dive master.
One very important point that I need to mention, we try and use every available resource that is at our disposal. So be it the dive stores, be it EMS, who we have on board with us, and obviously our chamber. So before we even leave the dock, I'm making a phone call to Spring Hill Medical Suites. And I'm always fortunate enough to meet up online, by phone, one of the most unbelievable agents that Spring Hill Medical Suites has, a woman by the name of Wendy, who always answers the phone. And I don't know if Julio, who's going to be talking at the end of this, hired her specifically for this, but there's nothing better than if you are all stressed out because you've just had an incident on your vessel, to be able to talk to somebody who's calm. And Wendy is really calm. So before we leave the dock, I make sure that I call Spring Hill Medical Suites, the chamber, and ensure that they are open and available.
Hey, Paulo, I just realized that you reminded me that I did not introduce some of our folks from the Spring Hill Medical Center. And Julio Garcia is back there. He runs the chamber. Julio, please stand up. And we also have Ed Adams. He's also a nurse with the Spring Hill Wound Center and also works with Julio. From Baptist Healthcare, we've got Dr. James Sellers is here. Dr. Sellers, thank you. And we also have Robert Sims. Robert is EMS regional manager and has numerous years. I've known him for 30 plus years in the diving. And as I said, we have Jim Chimiak online. We also have, did I introduce Jared Aliff? He's our surface safety support. He's a volunteer firefighter with the Escambia EMS. Thank you.
Thank you, Robert. So, divers, you all suited up?
Yeah.
Okay. I just want to complete our dive log. Robert, what is your tank number?
626.
We are running nitrox today. What is your percent of oxygen?
32.
What is your air in, your PSI?
3,000.
Mark, tank number?
484. 484.
What's your O2?
32%,
And what's your air in?
right at 3,000.
Okay, divers, the dive plan for today, you're going down to 90 feet. Going to do it for 20 minutes. I don't want you to exceed 27. If you can, don't exceed 25. So let's back off. I know you guys can do 33 on 32, a blend of 32 at 90. So let's back off 5 so you don't go into decompression. Keep in mind this is a no decompression dive. Okay. You know what your task is. Robert, you want to go over your task real briefly?
Yeah, we're going to, we'll do our standard artificial reef monitoring. We'll be looking for any debris that we can remove. I have a bag for that. We're also going to be looking for lionfish. And then I'll be recording my typical reef parameters.
Okay. Mark is going to act as your, he's going to be your support. Okay. So Mark, you're going to attach your dive reel to the anchor when you get down there?
Correct. I got the
Okay.
dive reel right here, and we just hook in right at the anchor.
Okay. So let's just go through our pre-dive checklist. You got your weights on?
Yes.
Got your weights in?
Yes.
BCD on?
Check.
Yes.
You inflate the hose and squawk it connected.
Yes.
Is your air on?
Yes.
Yes.
Okay, test your primary and your alternate. Inflate your BCD, hit it. Make sure your inflate and deflate buttons are working. Okay, and hit your squawker. Are your straps buckled?
Yes.
Yes.
Gauge is secure.
Yes.
Yes.
You have your knife?
Yes.
You have your dive computer?
Yes.
Is it on or is it water activated?
Water activated.
Okay, we're missing a dive computer.
That's why we have a checklist.
Slate and pencil.
Got it.
Yes.
Mark, you got your dive reel.
Yes.
You have your tools for this project.
Yes.
Emergency safety marker.
Yes.
And signal devices.
Yes.
Yes.
Okay. Who's going to be taking a camera down?
We're not going to take a camera because we're not going to be taking a camera this dive. I don't want a task load. We've got data to record, and we also expect to see some marine debris and lionfish on this. So we'll do a camera on the next dive.
Okay. Got your fins?
Yes.
Mask?
Yes.
Yes.
Gloves?
Yes.
Okay, surface air supply is down and on. Dive flag is up. Okay, divers, get ready.
So as a typical entry, we do a back roll off the boat, and then we meet up at the anchor. So we're going to simulate meeting up at the anchor line, and then we descend with positive contact to the anchor line. We come all the way down to the anchor. Then we check to make sure that it's secure without being hung in anything. If we need to reposition the anchor, we'll do so now. All of our dives are done with positive contact back to the vessel. So the dive master, one of his primary roles is to tie a cave reel to the anchor line so that we can come back to the anchor. When we're diving things like bridge rubble that are very difficult to navigate, that takes away our one of our big concerns about being able to make back to the anchor line. So that's what we typically do on our dive. So now that we've gotten to the bottom, we'll check our air and our time, and we'll verify how much air we've got. And now we'll do the actual recording of the data. We take reef parameters. We measure the depth of the top of the reef, the bottom, and the maximum depths. We record species, and I see some debris here, so we'll collect the debris. And I also see a lionfish, so I'm going to simulate spearing the lionfish through the head. And I see one hiding in here. So we've recorded all of our gear. We've been checking our air and communicating the amount of bottom time we have left. So now we'll signal that we're going up. We go back to the anchor line, and we maintain positive contact with the anchor line. We make a 2-minute stop at half our water depth for any dive over how many feet?
Anything over 60 feet.
Over 60 feet. So we're going to stop and wait for 2 minutes. Then we'll do our standard 5-minute stop at 20 feet. And then we'll slowly come to the surface, and we'll start our exit from the boat.
Now, while the divers are downstairs busy doing their task, on the surface is going to be the dive master, who also happens to be the boat captain. So we'll always have a boat captain and a dive master on the surface, also with a safety support. What the safety support is doing is he's going to be on the bow, and he's going to be looking at the bubbles. So at any time that the divers are underwater, there is visual contact with their bubbles and where they're going. If those bubbles suddenly start separating, you've got 2 separate bubble streams, we know we've got a problem. So we start gearing up for that potential problem. There may be a rapid ascent somewhere, there may be an ascent elsewhere, there may be a current that we don't know of. So that's what surface support is looking for. That surface support also swings in as a rescue diver. If we've got or rather rescue swimmer, if we've got a diver come up and he's not anywhere near the anchor line and he's in distress, that surface safety support is going to don fins and mask and swim out and get that diver. In the meantime, the captain is preparing the vessel to break away and pursue the dive that is seen. We leave the anchor attached. We've got a buoy attached to that anchor in case the second diver is on that anchor busy doing his safety stop. So we have planned the contingency in case the divers get separated. So that's what surface support and myself are doing in anticipation for the arrival at the end of the dive.
Yes, sir. And we also have our submerged, our buoys, SMBs that we keep in our BC pocket that's online. And we also have signaling devices. We have mirrors as well as whistles. So, and we have the powered squawker. So we're going to simulate coming up on the boat, and now we're going to be transmitting our dive information to Paulo.
Okay, divers, welcome back. Everything go okay?
Yeah, everything's good.
Excellent. So, Robert, go ahead and give me your air out.
Air out is 1200 psi.
Okay. And how many minutes did you spend at what depth?
We were 90 feet for 20 minutes.
Okay. What was your time to the first stop?
23 minutes.
And give me your total dive time.
Total dive time was 31 minutes.
Thank you. Okay. Mark, what was your Depth and time at depth. How many minutes? Actually, go ahead and give me your air out first. What was your air out? Hey, Mark.
Yeah, hold on 1 minute.
Okay, okay. You got your gear? Okay, good. Mark, hey, how about that air out, mate?
I can't remember.
Mark, just check your gauge, man.
I don't really remember where my gauge is.
Let's check it.
My arms.
What's up, man?
You doing okay?
Kind of hurting. My arm's kind of hurting.
All right.
Okay. Hey, guys, Jared, go ahead and get him to the deck. Mark, we're going to put you down.
Yeah, my arm's really hurting.
Okay, go ahead and get his gear off. Turn his air off.
Have a seat.
Robert, go ahead and read me his gauge. So we've got this on record.
He's got 600 psi, and he had the same profile as me. We were together the whole dive.
Got it. Okay.
Here, let's lay down. Lay down. Go on your left side. Lay down. All right. Grab the O2, please. What else hurts?
I don't know. Just really, my arm's killing me.
All right. We're gonna get you on oxygen.
Don't feel real good.
Yeah. Yeah. Just lay down.
Oh man.
All right. We're gonna put you on O2. We're actually not gonna hook up our O2, but we have a rebreather mask, a band regulator with a non-rebreather. We have an oxygen, 100% oxygen with a demand regulator and a non-rebreather mask. And our protocol is to put the diver on 100% oxygen as soon as we suspect that it could be a diving-related injury, and we'll start our patient assessment checklist. We've got each diver has a set of dive slates that has all his personal medical information on it, so that if we have an incident like this, all the information is available to us, and we can record on it and send this with the diver as needed as he goes to EMS.
Okay. So, Jared, go ahead and keep monitoring your patient while you got eyes on him. Okay, you're on the phone to 911. You're going to get hold of EMS. Robert, go ahead and get hold of the coasties. Let them know what we've got. I'm going to prepare the boat to leave.
Mayday, mayday, mayday. This is Escambia County Marine Resources. Escambia County Marine Resources. Yes. Escambia County Marine Resources. We are at anchor at Escambia County Reef Site number 10. We're at 30 degrees, 10 minutes, 0.44. 10.44 minutes, 87 degrees, 11.22 minutes. That's 30 degrees, 10.44 by 87 degrees, 11.22 minutes. Over. So we're simulating contacting and communicating with the Coast Guard, and our purpose is to establish contact with the Coast Guard as well as EMS if we have a working cell phone, so that we have two means of communicating. After we establish contact, we request the Coast Guard to tell us what their response is going to be. Are they going to send a surface vessel? Are they going to send a helicopter? Or do they want us to get underway? So according to our discussion with the Coast Guard today, their preference would be for us to get underway and head to Station Pensacola, just inside Pensacola Pass. So we're going to facilitate communication with EMS so that EMS also knows that that's where we're headed. So we've got our patient on 100% oxygen. We're making him as comfortable as possible. And once we get underway, we'll have a neuro exam by our dive master or our emergency first responder.
Okay, let's go through the. At this point, and I know it's all very calming here, but when you're out there and this is actually happening, you forget the simplest of things. Like you fire up the engines and you still got lines in the water. So we also have a checklist for that, and we do that even if we don't have an incident. So divers are in.
Divers in.
Crews in.
Crews in.
Ladder up.
Ladder up.
Lines in.
Lines in.
Dive rigs up.
Dive rigs up.
Flag down.
Flag down.
All gear stashed.
All gear secured.
Everyone secured? Okay, fire up. Bring me forward. Let me pull the anchor.
All right, so at this point, we would pull anchor and get underway, and we would bring Mark to our EMS rendezvous point at Coast Guard Station Pensacola. And at this point, I guess, Robert, do you have any thoughts about where we could take a different route?
I don't know about a different route, but I would encourage that Coast Guard station for 2 points. One, we can facilitate landing an aircraft there as well. The other point for the ground units is an easy exchange. So one of the difficulties we had if we beached up at Port Pickens is logistics. So if we get you across the bay onto the mainland area, that's an easy transfer, and that way we can keep the continuity of care moving. So that'll be a critical spot there.
Thank you, thank you. So if all works well, we're going to have an ambulance transfer the patient to one of the local hospitals. And since we have Baptist Healthcare Emergency Department staff here, I'll turn it over.
Thank you. Real quick about me, just so you kind of know where I'm coming from. Doctor of Nursing Practice degree from Florida State, which I'd appreciate if we don't talk about that part of it. Board certified as nurse practitioner, both family and emergency practice. I'm finishing up a postdoctoral fellowship in critical care nurse practitioner right now. I'm a master diver myself, and 20 years of pre-hospital experience, 15 of which was in the helicopters. So I've been to the Coast Guard station a lot, including the one down close to Panama City, to make those transfers over to Mr. Julio back there. Yeah, at Spring Hill. We will follow the same kind of systematic process that you saw on the boat. As soon as those signs or symptoms of a decompression injury were recognized, what did they do? They jumped right into action. They recognized those signs or symptoms. When they get to the emergency room, hopefully would have received in a pre-hospital report that this is a dive injury. We'll want some kind of report over the radio so we can get our resources within the emergency room ready. In most cases,
That's what we forgot.
yes. In most cases, this will go to a trauma room. May not be the trauma team, but it'll be the ER team initially that will be taking care of this patient. Once they get there, we'll do the same kind of thing. Start with a systematic process. What is their mental status like? What other complaints they have, like muscle pain. All these signs of DCI, DCS, or a bubble somewhere in the arterial system, we'll focus our treatment on that. Now, there's a lot of things going on at the same time. Patients being put on a cardiac monitor, labs are being drawn, IVs started. Any of the dive injuries I've worked in the emergency room, one of the first things I always bring up, someone's got to call Dan. Now, we need to have some information to give them, but we're going to get them on the phone, and automatically we start putting out phone calls to the helicopter transport services, and there's many around here. I can think of 5 to 6 off the top of my head in about a 100 to 200 mile radius of where we're at right now, to see who's available, what's the weather like. They can only fly in certain weather. The information that we're going to be trying to gather is what was the dive profile, because that can help us predict what injuries we're looking at. We'll need a good medical history on the patient. We always say in medicine, common problems happen commonly. Everybody's got hypertension these days. Hypertension meds, some of them don't do well in the dive world. So we would look at that medication list and see, are they at increased risk for a dive injury? All those things are being considered. One of the things we also be looking at is something called blood gases. That's a test that helps determine how well is oxygen getting in, how well is CO2 getting out. Those are very important tests. If we're suspecting gas bubbles, then we're going to do a certain kind of scan, probably with some contrast, to see if we can find where that gas bubble is at. Is it in the lungs? Is it in the brain? Those, again, will dictate how we treat the patient. The main thing is that we've got to get the patient, if they're having a true compression injury, to get them out of the emergency room to more definitive care. We don't have a dive chamber at Baptist Hospital, so the patient should not stay there if we feel this is going to be a decompression injury. There's very few things I can think of that we would not transfer someone over for. Sometimes there's a pulmonary rupture that may not entail a gas bubble, that may just need something like a chest tube if there's gas in the chest. But most things, we're going to assume it's probably decompression injury and try to get the patient out of the emergency room as soon as possible. Questions? We do that later, right?
Yeah, we're going to have questions as soon as we get through our scenario. We're going to be pulling up Julio's presentation, but we have Jim Chimiak online. And Jim, do you have any kind of input that you'd like to give in at this point in the process?
Not to slow the meeting down, but essentially what you have to do very quickly is figure out, is this bubble disease? And that's primarily what you need to do. You have to be very careful about doing a lot of unnecessary testing and imaging studies that will delay this person's transport. It's probably reasonable to call up the chambers in the area once it starts to look like it is bubble disease. Essentially, we're looking for a neurologic problem. That's primarily what you're going to see and have to move. It's going to be stroke-like in nature. It's following a dive. It's most likely bubble disease. The chambers have to be the chambers should be notified so that they can possibly start to gear up. Calling Dan is a good idea, particularly if the ER doctor is not familiar with bubble disease and what's going on with this. Looking for zebras at the time that it's, like you said, obvious things happen. Obviously, if it's following a dive, this gentleman is going to need transportation. The last thing I'd like to include is, does the transportation, Pensacola is fairly fortunate in that you have about a 1 hour ground transport time to Spring Hill. We can talk about that a bit. As far as using helo transport from Baptist to Spring Hill, is it better just to load him up in an ambulance and get it going? Sometimes the delay, the need to go ahead and transport by an ambulance to the helo, that sort of thing can often seem like it's quicker, but often can add delay. The altitude usually is not great enough to make any great significance, but if we can expedite and get him on the road to one of the chambers, and finding out that you don't have a chamber capability at Spring Hill, the idea is to go and move on to another chamber facility. And that's, at this point, I don't want to take up too much more than that, but it boils down to, once you figure bubble disease, move this gentleman and get him to definitive care. Thank you.
Thanks, Jim. In our dive slates that we attach to our patient's wrist, we have Dan's number. We have our Dan ID number on here, and we have all the information that we have recorded about the dive profile and all the pertinent information that gets handed over to the emergency room doctor. So hopefully the diagnosis can be done expeditiously. Yes, and also the neurological check. All right, so Julio, do you want to go ahead and do your presentation?
Yeah, I can. I'll run through it fast. I mean, anybody who's been here before has heard me talk about a lot of these things previously. I'm glad I could meet Dr. Sims. We have never had a chance to meet. I think this is one of the issues that's prevalent along the coast, is everyone operates in individual silos. Meetings like this go a great way to help foster communication among the community. The scenario setting that you've projected is fantastic, but I'm gonna now sprinkle in a little dose of reality to it, the way things really happen. So this is part of the things that blow my mind about the diving industry as a whole in the entire nation. So we have 3 million divers recreationally that are certified in the United States. Millions of dives occur all throughout the United States each and every year. We have a beautiful coast here on the Emerald Coast. In fact, the logo for my unit now is the Emerald Coast Ben's Watch, because we are the only recompression facility that's willing and let me emphasize that, willing to treat the diving injury. And that is going to go away because more and more chambers are going to the wayside. And it's not a matter of capability. All chambers are able to do the United States Navy 6, which is the standard recognized treatment for a diving injury. There is no difference in my capabilities or any capability of any hospital along the Florida coast, period. End of story. There are approximately 80 fatalities in the U.S. And Canada each year. And these are our cases that we received for 2022. So when you look at everything in red, anything in red is greater than 12 hours time of transport from time of injury. There's a total of 21 cases that I have, 18 cases that are listed here, and a total of 23 cases that I know of total for 2022. So that means my hospital treated 18, 5 went God knows where. I have no idea. I know 1 went to Birmingham. I know 1 went to Orlando. I know 2 went to Gulfport, Mississippi. Okay, and 1 never showed up. I had the dive boat captain call me, describe a completely tremendous neurological hit. Patient never showed. I had a patient last week who was seen in the emergency room in Navarre and released. Never showed up. Okay. Why? Because ground transport was going to take too long, so the patient left against medical advice. This is reality. Okay, we can talk about conjecture, we can talk about scenarios. I'm telling you, real life, 2022, less than a week ago. Okay? When we look at where they're coming from, the vast majority of all the diving cases I treated are from the Northwest Florida Panhandle. So we've treated 18. Of those 18, 13 were male, 5 were female, average age 40 on the males, average age on the females 46. Did these sound like young, healthy Navy divers or airmen? No, right? This is the population we're treating. And in order for me to get an average of 40, you can imagine where the high end is, okay? Because the low end is 18. So where are they coming from? I got 1 from Mississippi, I got 2 from Alabama, and I got 15 from the Northwest Florida Panhandle. 15. Again, I know of 3 more from the Panhandle. So what are we worried about? This has been illustrated and discussed. What we're worried about is a pulmonary barotrauma, which leads to arterial gas embolus. That is just like a stroke. The only difference is it's not a clot, yet it's a bubble. But guess what? Bubbles attract these little things called platelets. And platelets aggregate, or they clump around those bubbles. And now all of a sudden we don't just have a bubble. Now we have a little clot running around. And where do they like to go? All kinds of places that they're not supposed to be. And then the body recognizes this as a foreign body. So then it goes into what's called an inflammatory cascade. It starts releasing all kinds of little enzymes and white blood cells. And you know how you feel all achy whenever you've had an accident or any other kind of inflammatory process? Well, this is happening throughout the entire body. So it's related to Boyle's law of gas. You're very familiar with this if you're in the diving industry. What we see a lot of, unfortunately, is related to the largest change in those first 10 feet. So when you look at the pressure change that occurs in diving, the first 10 feet, you have a 33% reduction in volume in that very first 10 feet. I can take a breath off a compressed air off a cylinder in the bottom of a 3-foot pool and stand up and blow my lungs, okay? That's how significant the pressure change is. Also, we're talking minuscule amounts of pressures in order to blow the little air sacs that are in your lungs, and those are called alveoli. Most common places where we see blocks for sinus squeezes or ear squeezes is in the first 10 feet. In 23 years of treating diving injuries in Mobile, I have never, ever seen an inner ear decompression illness. I thought 3 this year, 3. I got places calling me from other places in the country. So what did you see? How did it present? How did you treat it? This is how rare it is, but yet we saw 3 in little old Mobile. So pulmonary barotrauma, first 4 feet. Since we're talking about Halloween, this is my biggest nightmare right here. Anybody recognize it? What is it? Yeah, it's a gas chamber, all right. It's the talk box over at Vortex Springs. I've received 3 18-year-old males with arterial gas embolus this year from that talk box. Someone's going to die. Luckily, these people did not die, but they have no training. They're going inside this box. They're breathing compressed air, and what happens at that point? They're a scuba diver. And these kids are ascending to the surface and blowing their lungs and getting arterial gas embolus. Now, the young man that did this, you want to take a wild guess how long it took him to get to me? So here we are. We're talking bilateral pulmonary barotrauma. Bilateral blowing his lungs on both sides, and he's got air in his body that's gone to his brain. Do you think that's important? Is that an emergency? How long did it take for it to get to me? 23 hours. 23 hours. If I sound upset, it's because I am. Okay, it's ridiculous. Absolutely ridiculous.
Please, before you get too far away from that, what happened? Why?
To the child?
Sir?
To the child, how did he do? The child didn't fall.
23 hours with
I cannot answer that for you, sir. I cannot. You have to discuss that with your local EMS officials from here to Tallahassee. I have contacted the director of EMS for the state of Florida who told me I'll have to do an epidemiology study.
Wow. Thank you for that.
You're welcome. Something else that I find frustrating is that a lot of advocation that's done on behalf of the diving community is coming out of Mobile. I mean, I've said it before. Y'all have heard me say it. Nothing's going to change in this community or anywhere on the Panhandle until there's an outcry from the diving community. Why? If I ride my motorcycle and get in an accident right here on this street, are they going to refuse to treat me? They're not. Right? Any hospital I end up at. If a police officer gets shot in the line of duty, will he get treated at any hospital in Pensacola? But how about if he has a diving injury while searching for evidence or body? How's that even possible? The state of Florida operates and manages full-time employees of scientific divers, of over 180 scientific divers. They get hurt doing their job, you're going to ship them off? And let me tell you, nationally, I sit on the board of directors for the UHMS, the Undersea Hyperbaric Medical Society. This is not a problem to the Northwest Panhandle. This is a problem to the entire United States, and it's getting worse. We're down to 80 facilities in the U.S. that's going to treat diving injuries. 80 out of over 1,500. 80. Think about that. Amazing, isn't it? So the biggest cause of death is typically drowning. Hey, swimming's a hard sport, much less underwater. But look what's number 2. Arterial gas embolus followed by cardiac events. And that is why you have to go to the local hospital. We don't know if you're having a stroke. We don't know if you're having a heart attack. And both of those waiting and delaying to assess that while you're trying to find a recompression chamber could cost you your life. Now, conversely, do we need CT imaging? Do we need a bunch of other really high-tech technology imaging in order to diagnose the diving injury? No, we do not. There's no magic test we can run. In fact, we had a patient who had air coming from Panama City on CT image on her liver. How long did it take for her to get to me? 22 hours, all right? But they could see air on the liver. They thought it was a big deal. She was asymptomatic. It didn't hurt there. You know, if we had all the answers as related to diving injuries in medicine, it'd be a great thing, but we don't. So why does this patient get the bends or get some type of decompression illness and this one doesn't, yet they were on the same profile? We don't know. The most profound statement that I've heard this year, and Captain Casey, you'll enjoy this one. and I really truly believe the diver does not still grasp the words that came out of my mouth. I said, sir, do you realize that I just got off the phone with the chief medical officer, and he was in the room, of the Navy Experimental Diving Unit. And I asked her about your profile. And her response to me after looking your profile, Captain Sonia Waters, after looking at your profile and trying to place it into a dive computer at the Navy Experimental Diving Unit, was I would have to call the Chief of Naval Operations to get permission to run this dive. How amazing is that? It doesn't sink in. So let me get this straight. In order for a professional military diver to do some of the profiles that we see here on the coast, they would have to call the Pentagon to get permission to do it. Think about that. That's wild. I got treatment tables that I see, excursions, evolutions, 21 dives to 100 feet in one day. Why? Anyone want to take a wild guess? Why? Why would someone do that? Oh, lionfish. Oh, let's provide a cash incentive to a state and an area that will not treat the diving injury. Think about that. Amazing, right? Isn't that just mind-blowing? I think it blows my mind. I can't make it up. All right, so what do we see? Poor health. Very common. Again, you saw my average age of the people. Buoyancy control, environmental issues, equipment needs to be checked. That was a great job, by the way, guys, on checking your equipment pre-dive. Good job, Paolo. That's the way you dive. If everybody dove the way you saw, I would have less work. But that's not what happens. That's not reality. You got to understand that we use different terminology to describe both the arterial gas embolus and decompression illness. Decompression illness is related to dissolved inert gas and bubbles within the vascular system. Arterial gas embolus is specific to the arterial system, though, and it's secondary to barotrauma or some type of cardiac defect. Last patient we saw had no idea that he had a PFO. Well, we did an echocardiogram. Now, there's a good test to do. Oh, you got a hole in your heart. That's not good. Well, I've been diving 21 years. It's never happened before. Hey, your number came up. Happy, it's playing craps. You want to bet against the house and stack the odds in your favor as much as possible. How? By doing nitrox, by diving shallower, longer surface intervals, making sure you're hydrated. Stack as many odds in your favor. It's a sport of probability. As a motorcycle rider, my uncle says there's two kinds of motorcycle riders, those that have gone down and those that are going to go down in the future. I'm beginning to think divers are the same way. Those who have gotten bent and those who are going to get bent. Because what I see with these extreme profiles, and I know not everybody's diving them, is that the boundaries are being pushed. So barotrauma, again, you got an expansion of the gas in the alveoli, and they cause the little air sacs and they burst open, and then air gets into the arterial system, bad things happen. It looks like a stroke. Look at your symptoms, much like what you saw Mike doing, confusion. Ataxia means difficulty with walking. If you are a victim of a diving injury, ensure that the ER gets you out of bed and walks so you can watch as you walk. We have seen that so many times where patients get transported to us, and has anybody asked you to walk? No. Okay, well. And then they look like a drunk trying to walk because they have no balance issues. They lose coordination, they can lose consciousness, and may ultimately end up with death. Presentation of AGEs are almost specifically associated with barotrauma, but you're not going to find it on x-ray in almost half the cases. So if you don't see it, doesn't mean that they don't have it. You got to go with the symptomology. There's an illustration of it, the little black areas over where the alveoli have burst, and this is not a good scenario for your brain. That is a pneumothorax. All the black that you see around that right lung shouldn't be there. It should all be nice and white. That is the black line around the heart shouldn't be there. That's free air around the heart. That the young 18-year-old that I told you took 24 hours to get to me had this type of presentation. He had pneumomediastinum. So there was air in his chest cavity around his heart. People think that bubbles are round, not in the vascular system. They're hot dog shaped, they're spherical in shape. So what happens, why it causes such an inflammatory cascade? Imagine that bubble just shooting through your vascular system, and it's scraping the walls of the vessel, much like a train going through a tunnel. And so there's sparks flying everywhere. And that's what causes the micro tears. That's what causes the platelets to come in. That's what causes the inflammatory cascade to start. You can have spontaneous resolution, especially if you're getting O2. Even if your symptoms resolved and you had neurological symptoms, we're going to treat you. Even if you come to me, because I just had one. He was 24 hours out. Well, I don't feel anything. Okay, guess what? You're still getting in chamber. You know, so come on. Now, the big difference between an AGE and a DCS is onset of presentation. AGEs almost always within the first 5 to 10 minutes. As soon as they pop up, they're like, I don't feel right, something ain't right. They start acting confused. Again, it's like a stroke. It's a little mini stroke. Any serious neurological symptoms are going to be easy to identify. Now, DCS is a little bit more insidious. It's called a great mimicker because it can act like so many things. You know, is my shoulder really hurt because I was pulling on that AJ pretty good, or I was coming up the line, or, you know, any number of different things. Another problem with diving injuries, because it can be very subtle, is denial. They'll attribute it to anything and everything except DCS. Oh, well, you know, I got stung by a bumblebee 5 years ago. That's it. Yeah. Where'd we go? Yeah, there it is. All right, so when we're finishing up with AGEs, pulmonary barotrauma doesn't necessarily mean you have a cerebral arterial gas embolus. If you have a cerebral arterial gas embolus, doesn't necessarily mean that I can find detectable pulmonary barotrauma. Again, we go on symptomology. Pulmonary barotrauma by itself without any neurological symptoms, we're not going to compress you. Anytime there are neurological symptoms, period. Numbness, tingling, I'm not thinking right, I don't feel right, you're in the chamber. Why? Because it's your brain, right? So we don't want to play around with your brain. It's something that you sort of need. It's questionable sometimes, but yeah. We're going to get a chest x-ray before recompression, so you can expect that. If you're evacuated to us and your records didn't come with you, guess what? You get 2 chest x-rays. It's just, I mean, we got to see what your lungs look like, make sure that there's no pulmonary barotrauma in there and that you don't have any blebs. The standard of care, as you've heard, and Dr. Chimiak mentioned, also is surface level oxygen is the pre-hospital standard of care. Now, here's the problem that we're seeing. One is that once they arrive to the emergency room, they're taking them off the oxygen. Why? because they don't have any diving medical knowledge, and they say, well, their pulse oximetry or their oxygen saturation is normal. Well, they don't need oxygen. We're not giving them oxygen because their sats are low. We're giving them oxygen because there's bubble in the vascular system, and we're trying to off-gas that bubble. So if you are the patient, don't let them take you off oxygen. Leave it on there. Now, here's the flip side of that coin. If we have you on oxygen for 12 hours, which is the average time of transfer, it could burn your lungs. Now you got pulmonary oxygen toxicity when it's treating you in the chamber. So it's a double-edged sword. Well, the transport times are so long is what's taking the big problem on that. All right, this is talking about how you treat a pneumothorax. You really don't want to see it. You really don't want one. How's that? Okay, you don't want that tube going in between your ribs. There you go. Or the other fun one is we stick a needle right between your ribs. So your choice. Don't hold hold while you're making pressure changes, ever. Got to go to a really cool conference in Reno. It was a joint meeting between the Undersea Hyperbaric Medical Society and the Aerospace Medical Association. One of the treatments we did this year was on an Air Force pilot in training, which was a really cool young female. But the whole point of me saying that is there is a direct correlation between aquanauts and astronauts. Now, what blows me away, and when I got to meet these astronauts and shake their hands, is how many people have walked on the face of the moon? Who can give me that answer? Didn't I ask this before? Didn't I ask this? Yeah, 12, 13, somewhere right in there, right? Now, how many people have been to the bottom of the Marianas Trench and back up to the surface in the history of humanity? 4. So think about that statement. 4 people have been to the bottom of the ocean, the deepest part of the ocean on Earth, but we've had more people on the moon in outer space. They have to deal with pressure. The pressure here on Earth is much higher and much more difficult to deal with, okay, in terms of navigation, in terms of vehicles, building, and the pressures that they're going to withstand. My point in telling you that is astronauts don't just jump off a boat and say, hey, I'm going to go down to the, and go fishing. Actually, some of them do. But for the most part, they train up really well to do it. And my point to the diving community is train up. Don't wait for something bad to happen and to try to figure it out. That's the big difference, I think, that you see between professional divers and recreational divers. Train up, train for safety, decrease your risk for injury. DCS can go happen to anyone that experiences pressure changes on a plane and in outer space, the U-2 pilots, and of course, divers. We're looking for histories. Dr. Sims mentioned that we needed diving profiles. That's very effective in letting us try to determine, did you have a provocative profile? And we're looking for provocative profiles. It doesn't make sense if you weren't a provocative profile. Well, then it used to be termed an undeserved hit, but they don't call it that anymore. It's just, it wasn't provocative, so why did this person get it? Because we don't know. The answer is we don't know. But anytime you dive, anytime you're breathing a compressed gas and changing the pressure column around you, you're at risk for DCS. I have an opportunity to go do some work with caisson workers and tunnel work. Again, it's not just diving. Anywhere there's pressure changes, you have to deal with this possible illness. So this is a nice little illustration of a provocative dive. How many of y'all have done this lovely dive here? 202 feet, 23 minutes total dive time. Looks right about at 8 minutes of bottom time, right at 200, right? I mean, I'll take the average there. And then there was a nice little 67-minute surface interval between the two. That doesn't do diddly. It just moved in one residual nitrogen group. But look where that top line is. Did it enter the red? Oh, yeah, right? A couple of times. Right? Is that provocative? Yeah, that's a provocative dive. Now, I can show you the same profile from a scientific diver that never went below 60 feet. And it's going to be in the red. Yeah. Why? Because residual nitrogen. You got to account for it. You have to plan for it. The big difference between the professional diving world and the recreational world is planning. So what is provocative? Can be difficult to determine. That wasn't so difficult, was it? Multi-level dives versus tables. Anytime you exceed the 120 rule, so 60 for 60, 90 for 30. I know they changed a little bit in the last revision, 63 minutes and 93 minutes, but 33 minutes, but that's fine. Just make it simple. 60 for 60, 90 for 30. That's a quick way to get a reference of where you're at. Suspicion arises with us when there's dives greater than 60 feet. Air versus enriched air, short intervals, less than an hour. Even at an hour, I'm like, okay, that was the bare minimum. Repetitive dives, again, 21 dives in a day, it's a little excessive. 8 dives in a day, a little excessive. You don't see this in the professional world. Reverse profiles. What you just saw was a reverse profile. Look, dive 2 is deeper than dive 1, right? That's a reverse profile. So we've already described what we're looking for in gathering our history. Remember that we're looking for onset and when the symptoms become apparent. That tells us a lot, and looking at how to differentiate the two. Look at the symptoms. I mean, they're so general, so vague, right? So we see all kinds of presentations with this. Triage, I cannot emphasize enough that you have to call Divers Alert Network. They are like poison control for the diving world. And if you don't have their insurance, good God Almighty, I don't know what you're doing in diving. Because those airplane rides, I had one fixed wing transport from Panama City. Oh, that's about a $10,000 ride. You better have some insurance, man. They're expensive. The helicopter rides aren't cheap either. But guess what? If it's thundering, lightning, there's a cloud in the sky, I'm not being facetious, they're not going to fly. So now you're looking at ground transport. I had to call, again, I can't make this up. Y'all can call me, whatever you want, but it's the honest to God truth. So I had to call the EMS director at Bay County, and say, look, it's been 18 hours. What are y'all doing? She could have walked here by now. What is going on? And so he had to actually call outside Bay County and get another ambulance transport to come pick her up. What the public doesn't realize is there are only so many ambulance units in any given area any time. Then you have to have a backup, a fill-in, if they're going to be transporting out of town. Why? Because now you've left home base short. And they got to handle home base first, right? That's their job. Make sense? So don't assume that you're just going to get transported. You might want to know where it's at. So Divers Alert, we want you to go to the nearest facility because we want you to get evaluated, make sure it's not something else like a heart attack or a stroke. Again, know your pre-hospital procedural, know what's available to you in your region. And again, let me give you another example. Because of the current crisis in healthcare, where hospitals are massively short staffing, we can go on diversion at any point. I know of 2 divers that didn't come to us that were diverted to other hospitals, i.e. Birmingham, i.e. Orlando, and the guy lived in Mobile. How bad is that? So wait, my hometown won't take me and kicking me to the curb over to Orlando? Why? Because our hospital was on diversion. There were no beds available, and the patient was over here in Pensacola. You're going to be admitted. No hospital is going to treat you and just let you out. That's not the standard of care. That is not what is listed as preferred practices by the UHMS. It's treatment plus +1. So you get treated to plateau where you have no more symptoms, +1. Now, the other caveat is you have to be within 60 minutes of the recompression facility that treated you. Well, that completely eliminates Pensacola, so that's why you're going to be staying at my hospital. Make sense? May not like it, but does it make sense? Yes.
I have a quick question. I had to get life flighted a few years ago, and I was outpatient that same day through the one over in Alabama.
Where at?
Mobile,
Yeah. When was this? What year?
2021.
And we treated you outpatient. And you were staying over on this side.
Yes.
That's horrible. Won't happen now.
I didn't have to go into a decompression chamber either. I got life flighted over there just in
Well, then I didn't treat you.
because I showed signs, symptoms.
Okay, but then you didn't get treated. I mean, yes, you can go do whatever you want. I really don't care.
I was like, I just figured I'd ask.
Yeah. No. I mean, when you get recompressed, you have to stay within 60 minutes of that recompression facility. That is the standard by the Undersea Hyperbaric Medical Society, Divers Alert Network, and every other little professional organization out there. All right? Yeah.
We're going to have a question and answer with the microphone so it can be picked up on the recording. So,
Robert, you did all the rest of these. This was all the first aid procedures, and that's the treatment tables, and we are at rock bottom, people. You'll know when we get there. All right. I'll let Mr. Turpin take it over. I'll be around.
Thank you, Julio. That was I think that was a shock to maybe some people. Every time I hear Julio give a presentation, it reaffirms that we should all be focused primarily on prevention. And we have the most control over our own destiny when we plan our dives and when we execute our dives. But as our scenario showed tonight, we dove within the limits and something still can happen. And Mark did a great job of displaying some of the characteristics of someone who is in the early stages of decompression illness. So in our presentations, we have a couple of other folks that want to give talks, but I want to give everyone the opportunity. If we want to take a break, Mr. Chairman, is that the will of the pleasure of the committee?
At your discretion.
We've been in here for an hour. Can I see a show of hands? Who wants to take a break for, let's say, 5 to 10 minutes? Nobody. So, all right. So we're gonna continue on. If anyone needs that we have a water fountain and restrooms on the outside of this room, just take a right, and it's about 15 feet on your right. So we're going to let Paolo give a presentation about his perspective on safety, and then I've got Brady Hale is going to give a talk, and then we're going to have a panel of experts and an open question and answer period.
Thank you, Robert. So, we've all been introduced a little early on. How many divers in the room? Show of hand, divers. Wow, 90%. And on the board, good gracious. Excellent, I'm in good company. So, just to confirm what Robert said, every time we hear Julio come and give a presentation, well, it can do one of two things. The best is that you walk away realizing that there is professional help. The other is, I don't think I'm ever going to go diving again. You listen to this, but I came across a video online, so it has to be true, right? But it didn't seem staged, and there were several different scenarios of this video, and it's, have you seen the scuba diving dog? There are a couple of dogs that have been outfitted with a diving helmet, and they're on Hooker, which is, for those that don't know, it's surface supplied air via a line. You're restricted in the how deep you can go with that. But for these two dogs, one was in a swimming pool and one was in what looked like open water. It was merrily going along, alive, being supplied with its tender right next to it on scuba. So the point I'm trying to make is, heck, even a dog can go scuba diving. Okay? But what happens when that dog has his air supply interrupted? Unless that tender's there to help him, that dog's not going to make it. So when we dive, you just saw how we do it. We know how deep we can go on the kind of air mix that we've got for how long. We verify that not just on our computer, which is set to a conservative mode, but also with our dive tables. Be it Navy, be it EPA, be it PADI, or any of the other recreational institutes. And then we back off of that, so we get even more conservative. It seems as if people that go on their long-term trips, a week on a liveaboard, want to get in as many dives as possible. We don't do this kind of diving for recreation. This is scientific diving. So there's a task to be completed. I don't know if it's easier doing it that way or doing it recreationally, where you are trying to get the maximum value for what you spend on that particular dive. So you want to cram in it right down to the last minute. Well, today's diving is going to be different to tomorrow's diving, because physiologically your body's not going to be the same tomorrow as it was yesterday, as it was today. So you've got to compensate for that. I know this was a scenario, but it's happened enough times, and if you aren't a DAN member, and I'm not getting paid to say this, but if you aren't a DAN member, become a member. It is some of the most informative knowledge that you can acquire without having to attend a course. The kind of information that Dan has available for the membership fee is a bargain. When you read about the scenarios that have happened, that Dan has helped treat, there are so many of them where that dive profile isn't the top profile that Julio showed towards the end. It isn't aggressive. The person did everything within the limits. They had time to spare, but they got bent. So, what we try to demonstrate here tonight, and I hope I'm boring you, because I'd rather you be bored and know what I'm talking about than to be going out there and doing what I'm advising you don't do. Don't wish, don't hope, because luck is for horseshoes and hand grenades. Luck isn't for diving. Because Robert said right in the beginning, he is really, really, really fortunate that he didn't get hurt in his younger years of diving. He's become a lot more conservative in the way he approaches diving. So youth does have a benefit in being able to stave off getting hurt. But if you push it hard enough for long enough, it's going to catch up to you. But what if you do everything right and you get hurt? You've got to plan. You've got to prepare for it. Because when you're a diver, and if you are the diver, you come up, and it could be on the way back, 10 minutes into your trip back, you start feeling those symptoms, you start exhibiting them. If nobody on board has got oxygen, if nobody on board has got the faintest idea of what to do and what they're looking at, they may say, well, maybe you got indigestion, maybe there's a chili that you had last night. Maybe it was a 16th beer that you drank last night. I don't know. So that is what gets divers hurt. The I don't know. When you don't even file a float plan, when you don't even check that your radio is functional, when you don't even have the most basic fundamentals on what it takes to look at the symptoms that are in front of you from one of your divers, then you really need to question what you're doing out there. It doesn't matter about having insurance. That hurt that you've gone through could last you your lifetime. So what I'm trying to say is, be prepared. There are some outstanding dive shops in the Pensacola area that have got exceptionally well qualified dive instructors that will take you through just a host of courses. Go ahead and get your oxygen delivery provider. Go ahead and get your CPR qualifications. Learn how to recognize what DCS looks like. Go ahead and spend the money and get yourself some oxygen on board. I don't know, the last time I checked Dan's website, they actually, if you can demonstrate why you need it, they have some matching grants to help you pay for that oxygen. You may never need it, but damn, it sure is good to have the knowledge and to have the equipment on board, because that oxygen is imperative to help that diver, give them a chance to come back and dive another day. It doesn't help looking at the person right at the end. It doesn't help saying, Julio, you've got all of the responsibility for my dive. As much as we say, thank God for Julio, you got to take responsibility for your own safety. And that responsibility starts with proper planning, having the knowledge, having the equipment, knowing how to use it. Don't be that dog.
Thanks, Paulo.
Thank you, guys.
Good job. Thank you, Paulo. All right, Brady Hale's going to give a presentation, and he's got it online already.
How you guys doing tonight? Who's ready to go diving right now? Oh, me too. You know, I don't want to discount what the experts are saying by any stretch of the imagination, but I do want to put it in perspective for just a second, because I can see the room, just the life sucking out of it. Over 3 million people dive every year. They consider themselves divers, and we have less than 300 or 400 cases in the entire United States for DCS. Is it very important to heed their directions? Absolutely. But I just want to kind of put it in perspective. Diving is still fun. Diving is still amazing. It's something that we do every day, and people survive. It's not. Go ahead. So I want to talk to you a little bit about myself. My name is Brady Hale. I'm a senior dive master with Niue Dive Charters here in Pensacola. I founded Ocean Strike Team, which is a nonprofit that takes scuba divers and teach them how to do ocean conservation. And in my previous life, I was also a paramedic, so I kind of have a little bit of background in medicine as well. I can talk a little bit about it. So I want to beat the Dan drum just one more time real quick. Also not paid to do this, but we had an incident of a diver that had DCS, most likely had DCS, and it's one of the ones that Julio talked about that never showed up at the hospital. And even as a paramedic that spent years on the street doing assessments and doing emergency medicine, it had been a while. And when we had this guy, and it was a serious case, and he absolutely did not want to go to the hospital. One of the things that we did do at the dock, we called Dan. And Dan actually walked me through the assessment of this guy and some of the things that I had forgotten about, some questions that I didn't even think to ask. They were right there on the phone. So if you're in that situation where you've got cell phone coverage, call that Dan emergency number as the event's going on. The captain's calling the Coast Guard 911. If you call Dan and talk to them, they will walk you through and start to record a lot of the stuff that you may never even realize is important. And they record that information and give it to guys like Julio. So when they get to the chamber, they have that accurate, good information. So Dan's great, saved a lot of people a lot of money. So let's talk about usual suspects real quick. When it comes to fatalities in diving, and we want to talk about who's getting hurt. Who really is? Is it you? Is it somebody like you? Is it the other guy? So I'm not going to bore you with a bunch of statistics, but we're just going to go through a few slides real quick. By age and gender, this came from Dan's report from 2018. Like Julio talked about, it's that older generation, 50 to 59, 60 to 69. Males a lot more than females. That probably has to do with back in the day, the males were the ones that were doing more diving. Now we're starting to see that average up a little bit because you're having more females in diving. By years of experience, this was a kind of an obvious one for me. Most people with problems, it's their first year of diving. They're not experienced. Then as you get more experience, it starts to go down. But what's really interesting is that 10 plus, and I know I'm in that world. You know, you start to get real comfortable in diving. I've been diving for 10 years. I'm an expert. I can do all this stuff. I can do the crazy profiles that Julio talked about. So, you know, you see that in everything. As you get more comfortable, you get more brazen. There's old divers and there's bold divers, but there's not a lot of old and bold divers. So keep that in mind as you get that experience and start to feel a lot more comfortable in diving, watch yourself. By days in the diving series, this was an interesting one for me. So dealing with a lot of tourism and tourists that are coming down for 3, 4, 5 days at a time, it's real interesting to see the number one day, the day that they're there the first time, is the one that they have more problems with. And again, as they dive again, they start to remember stuff. They're not so crazy and they're a little bit more tired, so maybe they don't swim so hard, or maybe they don't do that third or fourth dive or 10th dive, whichever one. By type of diver. You know, this is another thing that was real interesting to me. Obviously, recreational divers get hurt a lot more than military divers. Even the dreaded technical divers, the one that we do all the crazy stuff, we're not getting hurt as much as recreational divers because, again, just like we talked about, we plan, we train, we don't go within our limits. Exactly. So let's talk about just a little scenario real quick and ask you a question. So you got a 58-year-old diver. He's overweight. He's done 35 dives in 20 years. Hadn't been in the water in about 8 years. So he's diving. He's real nervous about diving. It's been a while, but by God, he's an expert. He's got 35 dives. So he knows what he's doing. He's not exactly physically fit. He gets out of breath just putting on his wetsuit and his gear, because you know those wetsuits, they shrink in the closets. And so when you're in there and you're trying to struggle through that thing and you're trying to get it on, and golly, it's hot and I'm sweating a little bit. Now I'm getting a little excited, and I'm starting to breathe a little bit hard. And now, it's time to go. And so captain says, all right, pool's open. So I dive in, not me because I'm not fat and overweight. They forget to buckle their straps on their BC, on their waist strap before they jump in. So they jump in the water and they're bobbing on the surface. It's a little bit rough, and all of a sudden that wetsuit is turtling up and they can't breathe very well. And they pull that regulator out and, okay, I can do this. And they put it back down and they go underwater because it's safe underwater, right? So they dive down to 60 feet, and man, my chest is hurting all of a sudden. My arm's hurting a little bit. And I got a little tightness in my chest, but yeah, it's good. I'm just nervous. I just need to calm down a little bit. So they calm down, but they're still breathing super hard. And all of a sudden at 400 PSI, they go, oh crap, I got to go up. I got to get up right now. So they panic. They have a rapid ascent from the bottom, and they have a fatality. What caused that diver to die? Which one of those paths was the one that's the one? Barry? All of them, exactly right. There is never one thing, most likely, when it comes to a diver fatality. At any point in that chain or that roadmap, had they stopped and broken that path of panic, they most likely would have survived. So keep that in mind. It's never one thing when it comes to diving that's going to get you in trouble. It's a bunch of them. But what I do want to talk about is basically the 5 things that we see on a dive boat all the time. The things that are constant. Every time we get tourists that come on, somebody's got one of these problems. Number 1 is not familiar with your gear. The biggest thing we see is they don't understand or know how to use their dive computer. Your dive computer is your life. If you've rented one from one of the dive shops and they didn't give you a thorough understanding of that computer, stop and ask. Make sure you understand what that no decompression limit looks like on that computer. Make sure you know how to set your nitrox. Very, very important. Low pressure inflator hose. As stupid as this sounds, which button goes up and which button goes down? Which lets air out, which lets air in? For those of you who have rented lots of gear or used or borrowed different gear, as you know, that low pressure inflator hose is on different parts of that inflator is on different parts. Sometimes it's on the top, sometimes it's on the side. Sometimes you have 2 like this, sometimes you have 1. Know your gear, whether you rent it or whether you borrow it from somebody, because when it comes to a stressful situation, you can't stop to think what's going on. You've got to know. Buckles versus Velcro. We see this a lot. They jump in the water, they buckled the cummerbund, or they Velcroed the cummerbund, but they didn't slap the or strap the buckle. So when they hit, that belly pops out and that Velcro busts, and now all of a sudden they're having an equipment emergency. Inappropriate sizing. You know, I borrowed my brother's BC, who's 105 pounds and 5'2", and by God, I'm going to make it work because I don't want to spend the $30 to rent a gear. So we see that a lot. Inappropriate sizing. Maybe they went to the dive shop and all they had was that large, or maybe all they had was that extra large when they needed the medium. By God, I'm going diving, so give me that one. Check your equipment before you dive. Maintain your gear carefully. Lack of diving skills or out of practice. This is another thing that we see a whole lot of. Again, most of the people in this room look to be pretty local. And so, by the way, I promise I won't name you by name for the people that I've had to deal with this on stuff. Don't understand when to come up. You would think that would be so simple, that you're a diver, you're a certified diver, you've been through class. How do I know when to come up? I literally had to start putting that into a briefing of there's three reasons why you need to come up. One is a dive master, I tell you to come up. That's the most important in my opinion. Number 2 is I'm out of air, I'm low on air. Most people, for the most part, understand that part. I look at the gauge, it's really low. If I remember to look at the gauge, I can say, wow, I'm low, and I can come on up. But what shocks me is the people that don't understand the no decompression limit. They look at that number, or they'll look at that gauge, and you say, are you okay? Is your deco good? Yeah, it's great. I actually had a guy that was diving in gauge mode. So he had his dive computer on. It was not in where it was calculating its decompression. It was literally just a timepiece and a depth gauge. And I continued to ask him. I briefed everybody about it. Hey, how is look at your NDL. Make sure if it's less than 5, let me know. If it's above 5, give me the okay. You're good. And I continued to ask this guy, and I'm thinking, man, my NDL is getting low. His has to be low. And so I go and I'm asking these questions. He's like, yeah, everything's great. It's a wonderful dive. We're doing awesome. Until I finally grab his gauge and look for myself, and I see that he's in gauge mode, having no idea. He didn't know his gear, and he didn't understand the basic concept of I've got to know what's going on to know to come up. Dive within your limits. Now, this is also not for tech divers. This is for recreational divers when I talk about this. Not for cave, not for rec. You got to have your mind right, and you got to have your skills up. The Joe Patty barge at 40 foot of water may be too much of a dive for you if you haven't dove in 10 years. You've got to know what you're capable of at your point at right now. I don't care if you're a master diver. If you dove 200 times before you got here. If it's been 10 years, probably need to jump in the pool, or at the very least take a refresher class. And then panic. They panic and just shoot to the surface. I can't count the number of times that I've been that umbrella, or use the diver as the umbrella as they go up, and I'm pulling as hard as I can, making sure they don't go down. Number 3 is task overloading. This is something we also see with new divers and old divers. They jump in the water, they got 5 whole dives, they got a GoPro with a handle, they've got a pole spear and zookeeper, they got a spear gun, they got a marine debris bag because they're going to pick up all that trash, and they got a lobster bag just in case they see them. They look like a one-man band underneath there, and I know the people, they're all laughing because they've seen those people before, and you can't do that. That'll get you in a lot of problems. Master one task and then move on to the next one. I think Julio talked about Robert talked about task overloading in his thing. That is a big thing. Number 4 is overconfidence, and that gets back to know your limits. We see it all the time, and Captain Andy and I laugh a lot when we see those forms coming through, and they're an expert diver with 35 whole dives, but they've been diving for 20 years. So they've got to be an expert, right? It's okay to be new, and it's okay to be inexperienced. The best thing you can do on a dive boat, if you're not confident, is look at that dive master and say, man, I got 35 dives. Help me out. That's what we're there for. Almost every boat in Pensacola has their own dive master that gets in the water and is there to help you out. We're not trying to judge you. We're not trying to make you feel stupid. We want you to have the best dive and the safest dive possible, so the person that's the smartest is one that comes to me and says, I'm not real sure. I'm excited, but I'm a little scared. Number 5 is physical fitness, and this comes straight from a conclusion from the latest Dan report. If I can get most scuba fatalities occur in older divers and are related to health and fitness issues. If similar medical conditions and circumstances were to appear in a person outside of the water, death may be attributed to a chronic disease. Because symptoms presented in the water, however, the fatality is often attributed to diving. A healthy lifestyle, staying fit, regular medical checkups are prerequisites for a long, healthy diving life. Again, we see a lot, they're out of breath. Because they don't have the aerobic stamina to just put on a wetsuit in BC in the warm air. Diving in current, we'll see a current pick up underwater, and they can't physically swim back to the line because they just don't have the physical energy. Weak upper body strength. Once they get to the line, they're so exhausted they can't hold on. Well, that's just going to send you going down into the ocean. Weak lower body. They can't climb up the ladder. I can't count the number of times I've seen Captain Andy bending over and trying to help somebody up that ladder. If you don't have the physical ability to dive, don't dive. Jump yourself into the gym, do a little squats, and come back when you're ready. It's not that difficult. Increased lead use. Fat floats, just to be bluntly and honest. So you have to use more lead. More lead means you have to push more mass through the water. If you have to push more mass through the water, now you're breathing heavy, you're running out of air, you have increased load on the heart, increased stress, increased blood pressure, and then we can have some cardiac events. Stop, breathe, think, and then act. This will save your life. This will save your life if you get into a situation you don't know how to get out of, a situation that you're not sure what's going on. If you can stop, you can breathe, think through the issues, find somebody to help you, and then act. I breezed through those, so that's basically it. Again, my name is Brady. If you have any questions, I'll be around. Love to have you dive with us, and be safe out there.
Thanks, Brady, and thanks to everyone for sticking with us. We are going to take about a 5-minute break right now. We're going to bring a panel of experts up here for your questions and answers. So if you do need to visit our facilities, they're out this door to the right and about 15 or 20 feet on your right. So give us just a couple of minutes, and we'll be right back to part 2. Okay, we're just about ready. I'd like to get our panel of experts, the folks that we've invited to come up front. And our Marine Advisory Committee members will be the first. Yes. So we're going to ask the Marine Advisory Committee members, if you have any questions, the chairman will recognize you. And after the Marine Advisory Committee has a chance to ask their questions, we'll move out to the audience. And since you're sitting in the middle, you'll hold the mic and pass it whichever way you need.
All right, thank you to all of our guest speakers and our potential Emmy nominee actors that we had doing our diving emergency scenario. Do any members of the committee have any questions for our experts in attendance this evening?
I got a couple things. One's not so much of a question, but a comment, and that is there are definitely some shady boat captains around here. But I would say from experience being overseas and diving in the Middle East, we had a Navy dive unit there in Bahrain with us, and he had a side hustle as a dive master on one of the local charters, and he visited. He said dozens of boats before he picked up his side hustle, and he said he could count on one hand the number of boats that had O2 on board. So, here abroad, but I would definitely say abroad too, especially when you get into some third world countries, things like that. Check the boat before you go out. Make sure they have the necessary safety equipment. Talk to the dive master. Get a warm fuzzy from him or her. Beyond that, my big question for the emergency medical folks up here, what kind of training are we giving the local emergency medical staff about how to recognize and handle dive injuries? And as a follow-up, have anybody given any thought to everybody getting in a room and chatting about a protocol for how, given our limited treatment resources, you guys can work out how to treat these situations? And I understand why hospitals don't necessarily want to take on either you could say the burden, but also the responsibility of treating dive injuries. But we do have limited resources here, so it seems there needs to be some sort of flow of communication between all of you.
I think from an EMS standpoint, I'm answering for Robert as well, because I spent 20 years where he's at. Most facility or most agencies do have a protocol set that will include dive injuries and what they should do in the event of a dive emergency. As far as getting to the hospital side, I can say the reason why I'm here tonight is because I'm the only one in my group that dives. I was, more or less volunteered to come in, but I wanted to. I like this. There's not much training at the standard level of operation within the ER, in my opinion. Most likely the first person you're going to see when you come in, if we don't get a good report from EMS, and sometimes that does happen in the events. I've been in the back of an ambulance where I was too busy to provide a good report to the emergency room I was transporting to, or sometimes radios just fail. When I started, there were no cell phones. Everything was a radio report. Sometimes it just breaks down. So you just show up. In most cases, the first person you're going to visit or see is going to be a registered nurse, and there may or may not be some advanced training on recognizing those injury protocols. I've been in triage a number of times when a dive injury has actually come in as you're coming to the ER one of two ways. You're bringing yourself there, or someone's bringing you there. I've had people come in who were diving in a swimming pool and had that unfortunate event, just in a shallow pool, and they go into triage and say, yeah, my chest hurts. And those right questions about when did it start, what were you doing, may not always get asked, and that just adds to the delay. of getting that person out of there. I'd say, I'm not speaking on behalf of any hospital, but I was around when there were other dive chambers in the area. It all seems it was a financial constraint as to why most of those shut down. I mean, you know, I'll make this quicker. I can think of hospital statuses where they say, we're profit, we're not for profit. Every hospital's for profit. They got to make money to pay staff, keep those lights on. That's a tax status. But if there are services that they don't feel are being utilized enough, those services will go away, especially if they're not financially feasible for that service to stay there.
Mr.
And
Chairman,
I don't
can I
know that-
piggyback off of that question real quick?
Go ahead.
Is there any consideration that possibly, like when Julio mentioned that one person who seemed to have extensive trauma, but they were 23 hours getting over to him? Is there any consideration that a hospital may be holding on to a patient too long, trying to stabilize them for one thing, and not wanting to release them to go somewhere else?
To answer the question, it's not a question of them holding them onto it. It's the question of transport, which the hospital has no control over. So that's what I was trying to explain to people. So any EMS sector, any EMS region is going to have X number of vehicles in service at one time. And they may have some backups. But let's say it's during a rainstorm. It never rains in the South, right? We never get rainstorms. And there's a number of different accidents. Now you've taken 3 units out of that rotation. And so there's not enough resources in the community for the transport. And this is, again, not a problem just for Escambia County or Bay County. This is a national problem. But how do we address it locally? I can say that Dr. Ott, who's sitting here next to my left, Mr. Alex Fogg. Alex, will you stand up? Alex is the Director of Marine Resources in Okaloosa County, and he set up a meeting with the Director of EMS, and we sat there and we discussed, all right, well, what can we do better? The average transport time from Okaloosa County was 12 hours. What you saw, it didn't change all year long. Dr. Ott and I and Alex and all the EMS staff over there said, look, all right, well, there's 2 supervisors on any one shift. One of them will be tasked to follow that diver to expedite the transport. That's only Okaloosa County's resolution. Everyone needs to look at what resources they have and come up with some type of plan. They really do. And to this, again, one of the issues was being discussed is money. But my point to the entire community is millions of dollars come into the Florida Panhandle from the diving tourist industry. Millions. By the own Chamber of Commerce report, their own report says $4 million is generated to the city of Pensacola. Well, wait a second. You know, how about sharing some of that love to the diving community?
Can I just add one statement to specifically what you did say? I can't say that doesn't happen in healthcare. In some cases, perhaps. I can tell you from my experience, if I have a critical patient, I got to stabilize them first. My next things, I want them out of there. I don't want them in there anymore. But there is EMTALA, if you've heard of EMTALA, Emergency Medical Transport Acts. I do have to have that patient stabilized for that transport, even though I know that that man on the end on their Julio is where they need to be at. If they have no blood pressure to a massive gas bubble, then they may not be stable for the transport. So you gotta weigh that out, because that is a federal law. Yeah.
Glenn, I think you had a.
Thank you. Very simple question to our aspiring
Turn your mic
actors.
on.
Okay, a very simple question to our aspiring actors here from the prior demonstration. You had a well-known, recognized dive flag on your boat, and you also had the Alpha flag. What's the significance of the Alpha flag?
The Alpha flag is actually a navigational. It's a navigational signal that lets other mariners know that that's underwater operations. And unfortunately, most of the recreational boaters are not educated as a professional mariners are, but we cover all bases, and that's our philosophy, is that we want to keep that first domino from falling. If we can prevent something from cascading into an incident, a medical issue, and it was I think a realistic expectation that I have, that any time I get in the water, I could get bent. I could suffer some type of decompression illness. I've come to accept that and acknowledge that, but take responsibility that I'm going to take every preventative and precautionary step I can to try to prevent that. And I have a team around me that I have confidence that our training and our equipment is there if the worst case scenario occurs.
Mr. Chair. Robert, thank you. This has been a really fantastic symposium, and obviously a ton of work went into it. It shows how much work went into it, and thank you, Glenn, if you wrote the email to get the video here. Julio, I kind of raised a ruckus after last year and said we have got to get this thing videoed, because you all are putting so much time. You're driving over here from Mobile, and so it's awesome that it's going out to YouTube. I just want to I want to push back a little bit on the idea that got mentioned about how, well, hospitals' resources, it's too expensive, and we understand why. I don't understand why. I don't understand why we don't have a chamber here. And what bothers me the most about it is, I want to thank Rachel. For those of you in the room who don't know, Rachel lost her husband to a diving accident not too long ago. How many years, Rachel? Almost 6. Time flies in paradise, right? She has pretty much single-handedly pushed to make this event what it is, and Robert has really answered the call. Last year, Clint and Carrie put on a really great symposium also, but for the life of me, I don't get it. We've got 2 major industries in Escambia County, and one of them is tourism, and the other one is hospitals. And our hospitals make a crap ton of money. They could afford to do this. And it should not take a citizen advocate always to get things pushed along in Escambia County. Why should Rachel have to push for years and years when we've got a tourism industry and a hospital industry that should be working together to get this done? And no good deed goes unpunished. So please, I'm not picking on you, Doctor, and we're all so grateful for you being here, because Mark Faulkner needs to be the one that's answering that question, and not you, and Extension, and Sacred Heart. But do you feel free to say why you believe it is? I mean, is it just bottom line cost? Is it liability? If people raise enough of a ruckus for so many years, can we have a chance of having some care here? Or are we just going to keep relying on Julio to handle the entire panhandle over in Mobile, which, let's just call a spade, it's absolutely ridiculous. It's ridiculous, and in my opinion, it needs to change.
Was that more a rhetorical question for me?
No, I mean, I really am curious. Is it just money? Like, what is it, is it even talked about when they, why don't we have a chamber here when this is a diving destination?
So I've never been involved in any of those meetings. That's just my personal observation. But there's so many, and Julio can probably really speak to this as well as Dr. Ott. To have the chamber requires more than just a physical chamber. You've got to have the certified people who are there to run it, more costs. You've got to have the physicians that oversee the program. There's so many parts to that. Who's going to take call? Who's going to upkeep the chamber? And there's a lot to that I can't even speak to as whether it's feasible or not. Now, Julio and I really got into this a couple of years ago, and then I got kind of busy with COVID, and it all kind of fell apart. But there's more than just saying we have a chamber and bring your divers here. There's so many other parts to that I can't really speak to.
And maybe-
But it's cost.
Maybe I'm taking it from the wrong end of the stick. Maybe Julio could explain, why does Mobile think it's what is, so you guys value it and you're willing to do it regardless of the cost. And so why are you guys getting it right and we're getting it wrong?
Wow, great question. To answer the broader question, I presented a paper to Undersea Hyperbaric Medical Society when I was with the American College of Hyperbaric Medicine, and I calculated our costs over a year to have a 24-hour service, excluding the physician costs. So the cost for the nursing staff, it was an additional $70,000 annually. So it included overtime, included the shift differentials, included the average salary rate of all my nurses. And so each call team is 2 nurses and a physician, okay? 2 RNs and a physician. So I was able to look at that and then calculate my costs for a year. So $70,000. 2 FTEs, 1.75 FTEs at $40,000. I don't think there's a single hospital in this nation that can't afford that. So what does it really come down to? What physician wants to stay up all night long and get reimbursed for supervision of what's called CPT code G0227, which is how you get paid for 120 bucks. Okay, because when you calculate by the time the patient's transported to the ER, you show up, we get them ready, we treat them, we're going to watch the sun come up because it's a 7-hour night. Now that same physician is making less than my nurses are, less than my, if you extrapolate it out over that time period. So what does the hospital have to do? Well, the hospital has to make it more attractive to the physician to give their time, because time is money. And so then it becomes what type of stipend will be given for call pay for the physicians to take call, because they're not going to make the money off doing the service. So why, as an individual, would I want to give up my nights, weekends, for an event that happens, even this is a bumper crop year, 18 times in a year? Why would I do that? All right, so what you have to have is a group of physicians, first of all. It can't be one person. You have to have financial support from the hospital, and then you have to have physicians willing to do it and a hospital administration willing to do it. So the second part of your question was, why do we do it? In 2005, Hurricane Katrina hit our the Mississippi coast, and our hospital, Mobile, was hit with 100-mile-an-hour winds, nothing compared to Mississippi coast in Louisiana. But in a total of 3 days, we treated 28 carbon monoxide victims. Our hospital is privately owned by Mrs. Celia Wallace and Dr. Lee Wallace. She walked into the chamber room where we were treating a family of 4. Thank God you were here. My medical director turned to her and said, "You realize that if you take away emergency services, I'm not coming in. You can call, I won't be here." Because the 2 families that we were treating were doctors on staff. So at that point, the hospital made a commitment to the community, said that we will continue doing emergency services. Now, what I fail to understand is why Pensacola is willing to allow a hospital in Mobile to receive the recognition of being the supporting agency for SpaceX, to receive the recognition of being the supporting agency for an environmental protection agency, for being the supporting agency for Eglin Air Force Base, for being the supporting agency for Pensacola Naval Air Station. Because I can tell you, I use that to untold ends all the time. I am constantly, it's on my emails, it's on my taglines, tout the fact that I support the United States Air Force and military and all the governmental scientific agencies that rely on my services. So why hospitals in this area don't do it, I don't understand. I can't answer that.
Thank you. Any other members of the committee? Any questions or comments from members of the public?
Yes, we got at least 3 that are on deck. Please give us your name and your question.
Barry Shively. Mine is for Julio, because I'm. How many chambers are available right now in Pensacola?
Their Sacred Heart is a UHMS accredited facility. They have 2 Seacrest monoplace chambers capable of providing air brakes, which means they can do United States Navy treatment table 6. The problem with Sacred is they are not inside the hospital. As a recognized expert in this field, I would not treat the critical care patient in a freestanding professional building hyperbaric facility. Pensacola Baptist, their chambers are located within the main facility. They are also monoplace chambers with air brake capability. They also have 2 chambers. I don't know if they've added a 3rd or not. Then you have now here's the fun part. Y'all think about this one. It's not even the treatment of the patient on the front end. I can't even get divers treated on the back end. In other words, I do the emergency treatment. They're stable. They still have residual symptoms. They're completely stable. They're an outpatient. And I'm having to hold on to people 2, 3, 4 days inpatient because there's no facility that's willing to treat them in the Panhandle as an outpatient. Explain that one to me. All right, so anyways, then you got Gulf Breeze. You got Dr. Zant, who is a board-certified hyperbaric physician, does dabbles in a lot of weird stuff and off-label stuff, but he's there. He will not treat the diving injury, but he will treat you for a concussion. Then you keep on going east, and there's at least another 5 facilities between here and Tallahassee. And then Tallahassee itself has 4 different facilities. So yeah, there's the answer just on the Panhandle.
So you're saying that these chambers exist, but it's primarily for wound care?
I say these chambers exist and they select their indications to treat the non-emergent patient or the non-emergent indication. When you look at hyperbaric indications, there's 15 accepted indications, 11 have emergent implications. Doesn't mean that the patient's unstable. It means that they require treatment now, not later. And that goes for the family of 6 that I treated from Pace, Florida. Why would a family of 6, 4 children, 4 pediatric patients, be transferred to Mobile?
Hey, thank you. You described problems in funding, facilities, and transportation. What is the quickest way to get something changed and to move ahead and make this area safer?
In my opinion, this entire group needs to show up at the city council meeting. This entire group, everyone in this room, needs to show up at the Chamber of Commerce meetings and ask the same questions you're asking of me, of them. That's my answer.
I'll back that up. Not only city council, but state funding. Right, Senator Broxson, Representative Andrade, Representative Salzman, and complain. And I don't mean send an email. I mean get out a pen and handwrite a letter, because that takes time. And when somebody sees that you invested that time, they'll tend to listen more.
Some of you have seen, because I've posted it online before, in 2014, on behalf of this community, I wrote a letter to Congressman Bradley Byrne, Senator Marco Rubio. I've tried to contact 3 different governors for the state of Florida. Florida has a habit of natural disasters happening somewhere at the same time I'm trying to talk to these governors. So Julio gets kicked to the curb. EMS directors for the state of Florida. But again, it needs to be a larger outcry. And I think if we showed up at the Chamber of Commerce and asked these questions, at the city council, invite the media. Let the media ask her, because this has been reported. This is nothing new, people. This has been going on since 2010 when Baptist went offline. and it's only gotten exponentially worse. I mean, the gap is between Mobile and Orlando, Florida. There are 4 recompression centers in the state of Florida that will treat the diving injury. 4. They're not up here. They're all in South Florida. Miami, West Palm, Bradenton, Orlando. That's it. It's a dirty little secret. I've made many an article on it. It is Florida's dirty little secret. Let's invite everyone to come down here diving. Better not get hurt. I mean, I see it all the time. People coming in from Nashville or other parts of the country, and all of a sudden they're in Panama City. Now they're in Mobile. Their family's back in Panama City. Their condo, all their clothes. Now they got to get a hotel room over here. You know, it's crazy. And someone's going to die. And a couple of years ago, Robert, I guess you remember this one day, asked me to speak during the, and I had just had open heart surgery, and which is not a good time to speak, by the way, and never talked to anybody given an interview while under the influence of oxycodone. I'm just saying. So somebody asked me for an interview, and I gave him an interview, and the question was asked, well, what's it going to take, Mr. Garcia, for it to change? And I said, a body count. And apparently the body count's not high enough. And I got quoted word for word, and I had to call my CEO up and say, look, dude, I was under the influence of drugs. I don't know what I was saying.
And I'd add that this isn't just an issue that affects the dive community. Military aviation has had a number of rapid decompression incidents in the last, going on 10 years now. I personally medevaced 3 off of an aircraft carrier. And I'm being very clear, I'm speaking in my own personal capacity because that is a requirement by the DoD for me to say that. But it is an issue for us, and I fly in the T6 now. We had a rapid decompression incident in the T6 that required somebody to be medevaced about 2 years ago, I think. And it was over Missouri. I have no idea what their access was to a dive chamber because of where they were. I'm going to bet it wasn't great. And the reduction in these facilities has an impact beyond just the dive community because of that. And by the way, the T6 here has had rapid decompression incidents. Fortunately, nobody's had DCS.
Okay, we got another question from the audience.
This is actually in a question, this is in a statement, that just that some of the people in the room may not realize this, but Baptists did in the past treat divers, and they stopped. They made that decision to stop. And I have been there with two different divers that I wasn't bent, luckily, but I mean, they did do that. And it's my understanding it was a financial decision, but not like everybody's saying. It was because they can make more money treating wounds and that kind of thing. You know, when the diver comes in, they have to.
Mr. Adams, how long have you been working for?
Since April of this year.
Do we routinely treat wounds?
No, I agree with you 100%, Julio. I'm just making sure that you understand. Like, it was, you know, that.
Is it inconvenient? Sometimes we have
Yeah.
to shift patients around. Our patients are very understanding that there's an emergency coming in.
Exactly.
We'll either shuffle them around or we reschedule them, they miss a day. Guess what? They have a chronic wound. They're not dying.
Exactly.
They can wait a day and it's not gonna make or break their treatment.
Exactly.
All the time.
I just felt like there were some people who that wasn't really presented. That it was a decision, and I think
It has nothing to do with Baptists. This
Yeah.
is a much bigger issue in the
Right.
industry that it was much more lucrative to just do the outpatient because there was stakeholders at a very national level making $9 billion a year that got caught for Medicare fraud, and it destroyed the industry. Okay, but it did. We are where we are.
May I, Chair?
Anybody else in the audience?
Robert, I just wanted to respond really quickly to what this woman has just said. As a citizen advocate, nothing happens here unless you get really, really loud. That's just unfortunately the way it is. If you're not willing to get loud and make people uncomfortable, it's not going to change on its own. I mean, the hospitals aren't going to get done fighting over who's going to take our Baker Acts and just naturally go right into conversations about a chamber. It's going to have to be organized. It's going to have to be, persistent. It's basically like a war of attrition, and you've got to be willing to fight it. If you want it here, it's going to take everybody.
It's got to be brought out of the shadows. It's got to be brought into the light. And again, there's studies stories that have been done. I got a whole page of links just in this area. And when I say this area, it extends from Mobile to Tallahassee. But there hadn't been a public outcry to go with it.
Any other members of the public?
Okay, so I'm Rachel Wells. Probably most of you know me. And I'm not going to tell the whole story because it's some serious accusations, and I'm not going to get into that. But I have been saying since my husband died that Pensacola, Escambia County spends millions of dollars on tourism. Come dive our wrecks. Come dive our reefs. We have amazing things to see. But what they don't tell you is if something happens, we can't help you. And that is what I found out the hard way. I lost my spouse because of this. I lost my best friend, the father to my children. He wasn't a master diver, but he was with one. And they didn't do anything. The Coast Guard was never called. And a lot of things went wrong. And I'm now alone because of people's wrong decisions. And because nothing has been done about getting a chamber here in Escambia County. Why are we relying on Julio? Why do we have to? Because hospitals will not use their chambers for divers. And I have a lot of anger about this because he should not have died.
Thank you, Rachel. Anybody else in the audience? Mr. Chairman? Oh, Kevin?
Behind you.
Kevin Wade, 413 Southeast Bobble. I've spoken here many, many times. Thank you all. I taught thousands of divers here, and I had the luxury of doing most of my diving here while Dr. Chimiak was running that chamber on base. And I always knew my plan, whether or not I wrote it down, was I'm putting my boat right up on top of one of those seaplane ramps. And I'm stepping off and I'm saying, former Navy, I'm a diver. I've got I've had an accident, please call Chimiak. Because I had many of the shirts taking rides in that chamber. You know, when you say mono chamber, does everybody understand what that means?
It's 90% of the chambers in the United States.
90% of the chambers in the United States, they're small. Chimiak's chamber would seat 12 comfortably. Not only that, but there were several apertures so that things could be passed in and out. But that was my plan. And I felt absolutely like there was a gem here, and it always struck me very hard that everybody in here, and everybody up there, and all of you, we are at the collision of a self-regulated industry that seeks help from highly regulated industries, and money drives them both. It really does. The passions, and what I've heard from Julio more than once has been that the happenstance of the accident of the owner of the hospital coming in and saying, what's going on, and being told the reality. And what I really want to know is this a crowd? How do we get the help to say, hey, Baptist, you're building this brand new campus. It's time for a brand new chamber, and we don't want a mono-spaced chamber. And it's time to have the staff there that can do the same thing. What more does it take, really?
And we have the sign in the nurse's office.
And thank you all. This is like been the best MAC I've ever been to.
Thanks, Kevin.
Hi, I'm Dr. Janet Hoffman, and I had worked with Julio for about 4 years in Mobile on the chamber with him. And my question is more to the board than to the advisors here. And it is, where does the money come from all the tourism? Does it go to Tallahassee and then get meted out? Or where does the money go? I know in Baldwin County, which is where I practiced at South Baldwin for many years, almost all their tourism went up to Montgomery, and very little went back to Baldwin County, as they could use a lot of money for their schools, etc. Didn't happen.
May I? Go ahead. It's regulated a little bit different in Florida. Our tourism industry has mandated tourism development councils for every county municipality. So, for instance, here in Escambia, there's a board of various members that sits that includes one county commissioner, 2 city council people. You've got somebody from the hotel industry, etc. There are particular divisions, and we primarily get the tax money from something called the bed tax, which is so many cents on the dollar. We just got it raised finally to another cent. But the county is in charge of how they distribute that bed tax money within some very strict parameters of what state law allows you to do. With it, you can't just go throw it at anything. It's in the statute what it can be used for. I've been arguing for a while that we need to start putting the pressure on our Tourism Development Council to put the pressure on the hospitals to get the chamber. And maybe if we did throw some bed tax money at it, we get millions and millions of dollars, and we're record breaking every year. We continued to break records through COVID for our bed tax money. So maybe if we could develop some sort of a partnership where the county spearheaded by the Tourism Development Council, could advise the Board of County Commissioners to try to start working with the hospitals on how to fund this.
The bed tax, is that lodging tax?
Heads and beds, both vacation rentals and hotels. Of course, we do a really crappy job of collecting it on our vacation rentals, but we hit all the hotels, for sure.
We have more control locally in Florida over TDC bed tax because we have so much tourism, so much coastline, whereas in Alabama, there's 67 or 70 miles of coastline. So, of course, Montgomery wants to funnel it up there and then throughout the rest of the state, just like they do with their port, and dump all the money into that. Whereas, we treat our port like it's a, we don't even want to see it. So, right. So, but that's another can of worms. But
thank you, Peter.
Yeah, so we do have more control over it. So, anyone else from the public?
Me. Julio, if my memory serves me right, was there not a chamber in Panama City before they had the hurricane?
Yes, there was. There was two. What?
And we lost that after they had the
Yeah,
hurricane.
since 2010, the dominoes have been Pensacola and Santa Rosa. Then there's never been one in Destin. Then two in Tallahassee that went offline.
Okay. Thank you.
Thank you.
Dr. Chimiak is online, and we appreciate you being here the whole night, and hopefully you've got some great observations and information for us.
Yes, I do appreciate the opportunity to speak and the kind words that went on throughout the evening. This has been a long brewing problem. I've been there from the beginning. That was a great, thanks for the intro there on the account of, that's essentially how we ran the chamber there on the base. We tried to get divers that came straight in through the pass, and we like to see the exam table wet from the diver sitting there. And that was kind of the goal at the time to, try to expedite care for those divers. And they were civilian or military. Things have changed some. And during the same time, they had a very contentious case that occurred at Baptist that I think has made its imprint even today, and perhaps one of the reasons for the resistance for those that are still working at the hospital. It was probably not. It was definitely a very difficult case, and so as a result, you lost the one chamber out in town. I had both the chamber on base and the one up in the northwest corner, a PA and a cardiologist with their own resources actually put that together and had a very fine chamber that we staffed, and certainly we helped them when they couldn't staff it properly. And I think it's been talked about as resources, and to be able to staff these things, we did it voluntarily, meaning that we really didn't get the call pay and things of that nature that some folks require that really runs the cost up. As a result, we got interested people that would staff those the facility up there, and of course we had the fortune of having the Navy divers down there on base at the time. What we need is the support of divers. When you do get someone that steps forward and wants to take this on, it's not an easy job to do for a diver, for the techs, for the nurses that are associated with it. I think you've got enough info for it. But there's things that the dive community can do in addition to the financial support, always helpful. But the idea of the actual support from the diving community. One of the frustrating things is you're always on call during the most beautiful weekends, and those is when a lot of those dive accidents occur. But as was it Julio that gave the case of one or two cases of where the diver doesn't even show up. We'd stand it up, be up there all afternoon, all Saturday waiting, and no one would show up. And then come to find out that they blew off their symptoms. We have to, I like the idea of you guys are doing a very comprehensive approach, and that is prevention and talking about diving, talking about dive injuries, telling folks that expect to be bent. It's part of diving. I was a Navy diver for a long time, and essentially you knew that you would dive. You could dive according to tables. You could do everything right. Statistically, you could get bent. It's not a mark of some sort of a mark that you're going to, suffer from because you're doing it. If we can get past that fear or that, the curse or whatever you would call it, and get folks to go ahead and just come in and get looked at, and then get triaged off and get it and go ahead for treatment. That's the way we need to do it. The one problem I see is these are neurologic problems that we're mainly concerned about. So they need to be treated like stroke. They can't be he was swimming in a swimming pool and he has chest pains and that sort of thing. The same thing that we do for a stroke patient, the same level of urgency when someone goes through a simple FAST exam, they go through the ER department like crap through a goose. You have to have that same level of urgency when the guy says, I have a dive problem, that they have to go through that system the same way. And if the ER doc does not quite understand it, call Dan, call their favorite DMO. There's two of the best DMOs sitting there at the expert panel there, right there in the vicinity, that they would be more than willing to also talk to you about what's going on in your emergency room department. The idea of having a chamber in the hospital is not too far-fetched. Having that close to or near an ER department where it's staffed 24 hours with professionals that handle A to Z. Dive accidents are not difficult. Sometimes people will do presentations and they'll show their worst possible case and how terrible this or that is, but they're generally very stable, very straightforward cases. So the idea to be able to handle these, you could probably handle 80% of these cases in a simple ER department with having having a monoplace chamber. I love multiplace. I like to call out for it, but certainly a monoplace chamber could be put into this new hospital and something that should be advocated. The idea of your EAP, when the guys come ashore, you should have that. I love that scenario that you did initially, is showing folks that you have to start that connection process early. You got to connect with Coast Guard. You got to get EMS involved. You got to go ahead and start getting these people moved. Call Dan. If we are involved in the process, we even can help that ER doctor stop the imaging and things of that nature and move this person on to definitive care. As Julio said, he's not always there for you. We have to find a chamber that's available. And if Julio's not there, we're off to Gulfport or down south or maybe even north if we have to. But Dan will be there to try to get those divers treated. So having said that, I think that kind of goes through a little bit of the history there. I love Pensacola and was down there. It's a tough slog for your physicians that are up there taking care of divers all the time. That it is something that you guys need to support that group. And certainly as divers, you can go in and maybe take CHT training, support that. The best CHT sometimes are those that come from a diving background. You know divers, you like working with them. And it just made the job, it's something I miss, not being down there with y'all, actually being able to do that anymore. But the idea is that, support that group, and any sort of support, either your labor or financial, can go a long way to try to get this to happen. Dan's going to be there for you. If we have to fly all the way up to North Carolina, we will. We'll figure it out. So thank you so much for allowing me to talk here this evening. Do you have any questions or anything that I can help you with as far as some of the questions? There's one last thing I have to say. For boat captains, if you're out there, there's two things you have to watch out that you really need to move that diver quick and get the Coast Guard on board and even consider evacuating. Those are a deep blow off, say like off a risking or something, and you're down deep and you have a deep blow up, you're in for a very difficult case, a cardiopulmonary DCS case. The second would be that severe abdominal pain with tingling and numbness in those lower extremities. all take oxygen, get them moving, get that person down, and start moving toward shore. You've got to remember that you are driving the show. The idea is get back to shore as quick as possible, know where you're going, be able to tell the Coast Guard or EMS to pick this individual up. You may even need helicopter transport to move them. On occasion, we might even be able to coordinate and talk to the chambers themselves when we get these very difficult, time-sensitive cases. So those are the two you really want to pay a lot of attention to. And then we talked about other problems, and the problem we see with the older diver now is the differential just goes, magnitude greater. And so sometimes the apparent dive accident really isn't a dive accident, it's a medical problem. So I think that's it. Does anybody have any questions I can answer before I turn myself off here?
Thank you, Jim. I really appreciate it, and we look forward to. Are you going to be at DEMA this year?
Sure am.
All right, we'll look forward to getting with you there. I think that's probably a really good place for us as divers is to maybe get a special section at DEMA for a discussion on just this, because nothing could be greater for the diving industry as a whole than for us to improve the care available for the occasional diving injury.
Agreed.
Okay, we got another question from the audience.
All right. It seems like everybody here in this world, we move on by making money. All right. So, but it seems like in the medical field that a lot of these doctors are worried about more of getting paid than trying to help somebody first. So, I mean, that's just what I'm picking up here. I don't know if, I'm not saying everybody's like that, but it's what I've been picking up. It's, they don't want to deal with it unless they know that they're going to get paid first, which I know that's how the world works. But it just seems that there's a lot of non-care nowadays in the medical field. And I ain't trying to call, everybody out or anything like that. It's just...
I wouldn't say it that way. I would say more appropriate is that you don't have the facilities to work at. Your hands are tied. In other words, there's no chamber for which you could work at now. The one up, like I said, in Northwest Pensacola, as I said, I would go up there volunteer because she couldn't pay the services up there for people for have on-call physician, or even I think she paid her tech. I think that was it. But the nurse and myself, we'd come in for volunteer to do that and be on call for them. The problem comes on is you don't have those facilities anymore. To be able to turn the lights on those buildings, they might do it with a legitimate wound care facility by day and be able to take care of divers by night. But the problem comes on is you can't keep the lights on the facility. We can't work in those. It's not so much, greedy docs or, this sort of thing. I think it's more of having the facility. If I was like an ER doc, I was an ER in my previous years, but if I was an ER doc, to have the chamber in my ER would have been incredibly great to have. And the idea is, can administrators put that into the hospital? And they'll say it's a money-losing event, but there's a lot of money-losing entities in the hospital, and the hospitals and the doctors and nurses and staff all take care of these folks. Whether they can pay or they can't pay, they still can come to the ER. OBGYN, the labor floor, oftentimes is a very losing proposition. Trauma is a very losing proposition for hospitals, but they don't shut the doors, and they provide that service. So they're out there. I would say, there's probably some guys that are entrepreneurs in medicine and want to make a lot of money, but the idea is, I think most of them in there to try to help out and do good by their people. The idea is to have something available. It was so good to have like the one gent, I really like what he said, right up the seaplane docks, we'd send over the base ambulance to pick him up if he was in bad extremis, but We like doing that sort of thing. That's what we got into business for. So I'd have to take a little bit of uppage against, saying that it's a factor of not being able to come in and help people.
Yes, sir.
We do like that.
And I do appreciate that, but it just, before today, I was always under the impression, since I've been certified, that there was only one chamber, and that was over to the west of us. Well, I was educated today that there's more, but they only use them for wound care and all that. Well, is there, do the city, county, state give these hospitals grants or tax cuts or anything like that to where that they can fund this stuff?
No, that's what we're discussing. I mean, that's part of it. Yeah, I know that there's a grant.
It's a good question. I guess also
There's ways to fund it. Catalina Island funds their chambers out there, and it's through grant money from LA County. So if California does it, I mean, there's answers. The short answer is yes. There's ways to get grant monies, but someone's got a great grant proposal. Someone's got to follow it through. Someone's got to push it. It's going to take a group of people.
And just to piggyback quickly, is you asked the question of if the county funded this particular thing for the hospitals. No, not yet. But the hospital administration is at the BOCC with their hands out all the time, receiving taxpayer dollars for a lot of things. So we provide a lot of tax support to our hospitals here for various things. We provided a ton of it during COVID. So, but I did want to mention that he said the important word, and it's administrator. It's not the doctors that get to make those decisions. The administrators are the bean counters that decide what gets funded and what doesn't.
Long time ago, when I first became a program director, my medical director, who I still work with, said, Julio, there's 2 rules I want you to remember. Rule number 1 is economics prevails. Rule number 2 is don't forget rule number 1. And so you can not like it, but it's reality. So we have to address the issue of the economics of the problem and make it palatable for everybody, or it's not going to change.
I'd like to talk a little bit about the private chambers that are in hospitals that don't do any DCS. And what occurs is there's a huge manufacturer of chambers called Hologics, and they go into partnership with hospital administrations to get those chambers put in the hospital as wound care only. And they're partnered, both of them, in the... Pardon me? What?
Yeah, he sits on the board of directors for Hologics, yes.
Who does?
One of the presidents for Seacrest.
Oh, well, what can I say? I'm just telling what I see. And so a lot of input by physicians is not there. You are recruited to fill those spaces. I did that at South Baldwin also. I was trained in wound care by Hologics, but before that I was trained when I was with Julio at University of South Carolina in Columbia. So it's not as much, it's not as clear as it cut as it sounds and things. It's always, as Julio said, the economics. I do have to say, the person who is the head of the board at Spring Hill Hospital in Mobile, she is the widow of the person who founded that hospital. And she is a champion of a lot of these niche kind of care areas. And I have to say, I really applaud her for that. Celia Wallace.
Yes, ma'am.
So, that's all.
Thank you. Anybody else?
Dovetail on that. It's not only economics, but Julio hit on this too. It's resources. There's shortage of nurses, doctors, everything. Last call I took for a diving injury, I was there for 13 hours, and then I had to turn around and come back in the next morning, and that was on Sunday, and so then I had to go back to work on Monday. And so oftentimes when we're pulled for these late night diving accidents where we're there all night, they can't come in and work the next day, so we're working shorthanded. And so it is more than just.
That's right there why the outpatient world doesn't do it.
Yeah, so it's not just pure economics.
Well, it is, that's part of economics.
Brady?
Just two quick things, and I'm sure we're getting late and everybody wants to go home. I'm hungry too. I need something to drink. Two things, Mel, to your point. I think everybody in this room, I would say 90% of them are here because we're concerned about the chamber. The professional community, we talk about it every day. We're on the dive boat, and when we have tech divers on there, we warn them. We let them know today's not the day because Mobile's on divert, and we're looking at Orlando, so don't be stupid. That does affect tourism. That does affect people coming to Pensacola to dive. That's in the back of their mind. What happens if? So we're ready to champion something. We just don't know how to do it. We don't know who to talk to. We've talked, and we've screamed, and we've yelled, and we've obviously talked to the wrong people or don't have the pull. So I would throw it on y'all, and I would ask, help us help ourselves, maybe, that who do we talk to? How do we organize this thing? Every year we come in here and we talk about this. We have Julio come down and he yells and yells about we need a chamber here. And then everybody goes home and you know, we talk and we complain about it on the dive boat. So how do we move this forward in a real manner? That's edict number one. Question I have for Julio is there any other models? Is there any other way besides hospital-based chambers that you know about around the world that we can try to implement?
Around the world is not the United States.
True.
Litigious as we are, plays a big role in it. There's also standards that you have to meet. So there's the National Fire Protection Agency, there's Joint Commission, there's CMS, there's in order to say we get Medicare divers, so you got to meet those standards in order to do it. So simply, because there was a guy in Panama City who thought he was going to just put one out there and I'm going to treat divers. Oh, but no, ask him how many treatments he's done. 0.
You mentioned that there was a partnership between city in LA County. That's
yes, Los Angeles County and Catalina Island.
And
they
you're
provide a $500,000 grant to Catalina Island.
Is that how much it takes to run a chamber for a year?
No.
I mean, back of the math envelope. Back of the envelope math.
My costs on salaries for wound care, outpatient, inpatient, hyperbarics, for just my nursing staff is right at about $500,000.
Because I know I've been to the BOCC meetings when they're talking about budget, and they're talking about the windfall that they have, the millions of dollars, multi-millions of dollars in extra funds they have, just trying to find a place to spend it. Who's going to get it? And this may be a perfect example. I can be bought too. I told them straight up. I got plenty of ways to spend their money, but this could be a very good suggestion.
Brady, you and Carrie had it right when you were down at the TDC meeting. Unfortunately, you just have to ask and ask and ask and ask. You just have to out stubborn people until they're so sick of seeing you and hearing you that they just give in and spend the money. But maybe what we need to talk about as a committee together is whether this is an important enough issue. We haven't even begun talks on, we have begun talks, but we certainly are nowhere near to solidifying a 5-year plan. Maybe this is something as a committee that we need to decide whether this gets built into what we want to be doing for the next 5 years.
Well, I know that I've been to every meeting for the last probably 6-7 months, minus a few, and I've never seen a crowd like this. That's right. The diving community needs this.
Mr. Chairman?
Clint.
I've got 2 great takeaways from this. First, let me thank Robert and his team for putting this together. And let me thank the medical staff for them having the, the duty to come here and try to answer a bunch of questions. My takeaways from this are we have 2 different things that we're working on here. While we're talking about a chamber here in Pensacola, which we may need, when we talk about it, I think the need is there. But what we really identified was the cause of some of the tragic fatalities was our own action plans when something did not go the way it was supposed to. And Robert and his team has done a great job here today. And that's something, I've been a recreational diver, I'm a public safety diver, I'm a tech diver. And all through my my transitions through, I've seen how, to properly address those type of things. And we need to do a better job as divers, as charter boat captains, to make sure that we have everything in place to treat ourselves when something goes wrong. If you do that, then you make Julio's job or somebody, you make the medical staff's job that much easier, that much better, and you increase your odds of survival. We've got to do our part, and I think that's what this Diver Safety Symposium started at, was a diver awareness, and it's done that. We are now aware. Now we're identifying other needs in our community, and I hope we get those addressed. But first and foremost, it's on me to make sure I have my dive plan in place, I have my treatment in place. Dan, everybody say that, you can't say it enough. You never get in the water without being a member of Dan. And it's just a tremendous service that's there to help protect my life and help protect my divers. And even if, and I don't mean this in a bad way, I mean it as a compliment to Julio. If Baptist built a chamber here, if any of my team members need a treatment, we're going to go see Julio. We know him, we love him, we trust him. And he's done a great job over there. And I hope we don't take anybody back over there. But I did have one of my good friends, just as a reminder of everybody, did get a treatment this year. Poor hydration. Dove a perfect profile, poorly hydrated, had to go see Julio. So, but, it's on us to take care of ourselves, in the water, and then we rely on medical help when things go wrong. Thank you.
Mr. Chair. Thank you all for coming out tonight. I echo a lot of the sentiment. We don't usually get a crowd this big. Diving is not the only issue we discuss here. I encourage you all to please review our agenda that gets posted in advance. And when you see something that may be of interest to you, please come out. We solicit public comment. We don't get enough of it. And you ask, how do you get things done? And it is by advocating, both places like this, giving us ideas so that we can do the minimal business of writing a letter to the board or to some other entity. But the other thing is your direct action to the actual lawmakers. I don't make a law. I sit here and advise. I give my thoughts and pontificate, and Robert has to hear me do it every month, and he loves me for it because I love the sound of my own voice. But seriously, go and write a letter, even if it is an email, make a phone call. If you're a person of influence, ask somebody for a meeting. And that's how, if you want to know how to solve these problems, that's how they get solved.
I'd like to thank everyone for coming out tonight. What a great turnout. And thank you to all of our experts. I know that y'all are not getting paid to be out here, so thank you so much.
Yes,
Robert?
yes, and especially for those of you who traveled both from the east and the west. We really appreciate your concerns over this issue, and we will continue to have these dialogues. And it doesn't take just the diving safety symposium. I mean, as my counterpart in Okaloosa County, Alex and I talk at least a couple of times a month. And I know you had that great meeting over with the EMS folks in Okaloosa County. Our hearts and thoughts and prayers go to all of our first responders that are right now dealing with the aftermath of Hurricane Ian. And it was just an unfortunate timing event that prohibited or prevented their ability to participate tonight. But these are discussions that these meetings can occur in the future. And our next Marine Advisory Committee on November 14th is going to have another symposium. This is going to be about waterway management. So any of you that are in the audience, we would encourage you to attend that as well. And thanks again for y'all coming. I know you may have some folks that want to talk to you. If you would, those of you who would like to go ahead and leave the Marine Advisory Committee committee may have a couple of other items of business that they'll take care of, and we'll close the door out there if you want to have some conversations in the lobby. But thanks again.
Thank you, everyone.